I will start with the first candidate, like usual. This is a CNS cases. I think most of the cases related to the exam. Many cases are very common for you, but in atypical position, typical pathology, but in atypical location. So take care, my colleagues. Dr. Sarah, candidate one are ready? Is ready?
Yes, doctor.
Okay. Can you see my screen, my colleagues?
Yes, doctor.
Okay. Could you request control? Or shall I? Yeah, thank you.
I have requested.
Yeah, the only difference between this lecture and the RCR is that I will give a comment and some notes after each case. This is a 60-year-old female patient complaining or presented to the ER by sudden episodes of collapse. One second, one second. Give me the mouse, one second. Go on. Go on.
Okay. I am presented with axial CT without contrast in a 60-year-old woman. I am just
Yes.
scrolling. The most striking abnormality is the presence of hyperdensity at the fox cerebri as well as the cerebral gyri, indicative of hemorrhage, subdural hemorrhage, as well as subarachnoid hemorrhage. I am tracking it down. There is also some edema, which I can appreciate in the form of decreased gray-white matter differentiation. I can also see some hyperdensity at the right sylvian fissure. There is also a mild effacement of the lateral ventricles as well as the basal cisterns. I can see that the hyperdensity is epicentered at the suprasellar cistern. Going down, there is also hemorrhage or hemorrhagic densities at the prepontine cisterns. Going down, I can see that there is crowding at the foramen magnum, which indicates there is increased intracranial pressure and there is tonsillar herniation. This is a surgical emergency. I will immediately inform the referring physician. In my routine practice, I would also check other planes. If the patient is still in the scanner, I would like to do a contrast study just to see if there is any aneurysm in the circle of Willis, subarachnoid, because of the presence of subarachnoid hemorrhage. I don't see any intraventricular component. I don't see any hydrocephalus. So I will inform the referring physician of my findings, possibly do a contrast enhanced study. This is a surgical emergency. Neurosurgery needs to be involved. Uh,
Okay, leave the mouse one second.
yes.
The physician asked for MRI, and this is the MRI. Look, which sequence do you want?
I would like T2.
T2. Do you think T2 is the best sequence to detect bleeding?
No, flare. Flare is the best sequence for
What
bleeding.
else? What is the best sequence to detect bleeding?
Blooming, SWI. SWI
Okay,
or
and
GI.
what else? What about this one? What is this? What is the name of this sequence?
This is T1.
Yes. Could you detect the bleeding?
Um, yes, I can see hyperdensities in the anterior as well as the right sylvian fissure.
Okay.
Uh, Anterior interhemispheric fissure and the right sylvian fissure.
Okay. Look here.
Um,
What is this?
this is MR angio,
Okay.
MR arteriogram.
Okay,
I
okay.
can
MRI.
see, I can see that there is a connection between the ICA and the basilar. I think this is just the persistent fetal circulation. I can see that there is a aneurysmal dilatation at the
Yes.
anterior cerebral artery. This is likely the source of the bleeding for this patient, and the patient will be referred to urgent neuro intervention to possibly embolize this saccular aneurysm at the anterior cerebral artery. I would like to
Excellent.
view other views just to see if there is any, like it's in the ACOM, or I think it's in the anterior
What,
cerebral artery.
what is the most common site of subarachnoid hemorrhage?
It's the same site at the anterior communicating artery. That is the most common site, or any bifurcation can be potentially predisposed to an aneurysmal dilatation. But anterior communicating artery is the most common location.
Thank you,
I
doctor.
can.
You did very well. Thank
Thank
you
you.
so much. It was a case of subarachnoid hemorrhage, as you see here. If we revise again the CT, what happened here? There are considerable amount of interhemispheric hyperdensity material smearing the sulci, okay, and extending in the interhemispheric fissures, okay. Here, especially anterior, is the most sizable. So this is the site of rupture. Where is the site of rupture? The site of maximum or the largest hematoma, I think here. And if you look down here, there at the basal cistern and the circus of Willis, there are even in both Sylvian fissures, there are subarachnoid hemorrhage. You did very well, our doctor, when you mentioned this surgical emergency. Why? Look here, my colleague, what happened here at the foramen magnum level. And this is the most important sign. Look here, you shouldn't see, this is the medulla and the cord junction. You shouldn't see any tissue posterior to it. You shouldn't see this herniated part of tonsil or vermis. So it looks like from the axial some transforamen magnum herniation. This is indicate increased intracranial hemorrhage. Okay, this is very important. And if you look here also, you can detect that the cortical sulci is almost effaced. The next step should be CT angio. I don't know why they asked for MRI angio, but overall, this is the angio. This is the MRA. This is without contrast. We can do the MR angio of the brain without contrast, but the neck should be with contrast. The aneurysmal dilatation here. Which part is this one? This is the ACA, and ACA has many parts. Look here, my colleagues. This is the ICA. Inside the Sylvian fissure, it is just at the terminal part, it is bifurcated into MCA and ACA. ACA have 5 segments. It is not too much important, but for your knowledge, it has pre-communicating, post-communicating, and this part, this is pericallosal, and this one supracallosal, and this one post-callosal. So the aneurysm here in the pericallosal portion. This is very important for people who work in interventional radiology to know the exact segment. We shouldn't tell them يعني sporadically in ACA. Which part of ACA? He wanted to know a definite part. He wanted to, yes, AC segment 3. Okay. Why he wanted to coiling this part? This is very important. Okay. Look here, my colleague. This is the circulus of Willis. Very important in any exam. And this is pass or failed question if you missed one of this anatomy. This is ICA, okay? And many of the CT is normal, and only the ICA is occluded. Follow it, please. What happened? Follow. This is different segment of ICA. Up, it is bifurcated into 2 parts after the supraclinoid part, into the MCA and into the ECA. Okay, and this is the ECA with its segment. Post, this is this is pre communicating. This is post communicating, and This is the rest of ACA. So when you find interhemispheric fissure hemorrhage, think of ACA aneurysm. When you find any hemorrhage here or here in the sylvian fissure, think about MCA hemorrhage. When you find prepontine here hemorrhage, think of the posterior circulation aneurysm. Okay, this is very logic. Is it clear for all of us? Okay, this is the basic, very basic. Also take care when you are looking for the circulus of Willis about the ophthalmic vein. Ophthalmic vein, if you look, this is the ophthalmic vein, by the way. This one, I think. Okay, if you saw it during the arterial phase, okay, and enlarge it, think of or think about ICA cavernous fistula, carotid cavernous fistula. Somebody will ask, Doctor, this is the arterial? No, look here. This is not pure arterial. Look here, this is the venous sinuses. So this is late arterial, early venous. So this is normally to be seen here. This is superior ophthalmic vein. Okay, my colleague, is this clear for all of you? Any question? Anyone has any doubt about this case? The vascular system of the brain is very important. You must be presented with one case, either arterial pathology or venous infarction or or arterial anomaly. Okay? Very important. Why? More than 50% of the CNS or neurology patient presented with infarction, hemorrhage, whatever. So central vascular system of the central nervous system vascularity is very important from the anatomy and the pathology. Next candidate, please.
السلام عليكم.
Doctor, this patient presented at the ER after she is 50-year-old female patient presented to the ER after motor vehicle accident. Could you request the control?
I'm sorry, doctor. I'm on the phone, so can you please scroll
Okay,
for me?
I will scroll for you.
Okay, thank you.
For you.
Okay, so this is sagittal cuts of non-enhanced CT of the spine, cervical spine. I can see there is a fracture line through the. Also, there is increased distance between the odontoid and the base of the skull. Concerning for occipital atlanto-occipital dissociation. And
Yes.
yes, I want to check if there is any fracture in the odontoid process or.
Yes.
Yes, there is a fracture in the odontoid process as well as the posterior elements of C2 vertebra. The rest of the cervical spine appears unremarkable. I don't see any malalignment or any fractures. And there is air locules within the spinal cord, within the spinal canal and the soft tissue.
What is the name of air in the spinal canal?
I forgot the name.
No problem. Okay, what else? What is
And there is
this?
prevertebral soft tissue swelling.
Excellent. Yes, indicating
prevertebral hematoma.
excellent. Yes.
So
what's the next step? What's your final diagnosis?
So this is a case of atlanto-occipital dissociation. with the
Dissociation
fracture
or association? 1 second.
dissociation.
Dissociation or separation.
Yes,
Okay.
separation.
No, see,
With the fracture
the most accurate term, dissociation. But if you forget separation, very easy. So,
and
yes.
fracture also of the second vertebra
Yes.
with associated air within the uh, spinal canal as well as perivertebral soft tissue edema. I will I will inform the referring physician immediately as this is an emergency, and I will do an MRI to assess for ligamentous injuries and further injuries.
Thank you, doctor, so much. There are very important structure here, may be the source of hematoma here, and commonly injured in a spinal fracture. Look,
Um, the
what
vertebral
should,
artery.
what, yes,
So I
excellent,
should
especially,
do an angiogram.
yes, yes. Or you can check, have a look during the MRI. Thank you, doctor, so much. This is very important case. One of the basic cases, by the way. What happened here? This is a motor car accident. The basion, this is, we measure the distance from here to the tip here. It should not be more than 10 mm. But by your eye, it is very clear that is this decreased, very decreased distance. Okay, so this is a sign of atlanto-occipital dissociation. This is life-saving case, very important. Okay, and what else? What happened? Originally, there are some fusion between C1 and C2. Look here, and this is the confusing point here. There are a fusion. Okay, on top of this fusion, there are fracture here. Okay, and at the tip of the odontoid process. This is very important. And here, many fracture. And here, many fracture. This is very critical case. Air inside the spinal canal called pneumorachus. Okay. Besides that, if you have a look here, this is endotracheal tube. Why it is pushed anteriorly? Because there are a large perivertebral hematoma. We have a definite measurement at C2 and C6. Okay, C2 it should not measure than 6 mm, but it looks like at least 20 mm. So this is very clear prevertebral hematoma. This is life-saving case. It need meticulous research about everything. This patient also should go for MRI and the skeletal survey, because if you have a look here, you will find some rib fractures. In any patient, polytrauma patient, he must undergo a skeletal survey, X-ray, especially if he has major trauma like this. Okay, my colleagues, I think here also if we have a deep look, you can detect some pneumothorax, I think. Have a deep look here. I think he has some pneumothorax. See, he may have some pneumothorax here. May have. Okay, so all of this are very important site finding. Okay, because يعني some of them may be life saving. That is all, my colleague. See, I think the lung is not an healthy lung at all. Look here. The air extended here. So it is very important notes to be covered during any exam. Thank you, doctor, so much. Next candidate. Hello.
Yes, Stephanie.
I will
Yes.
tell thing in Arabic please. خدوا بالكم يا جماعة لما بيجي لنا فحص الاكزامينر احيانا بيبقى عايز يشوفك يو ار ا سيف راديولوجيست ولا لا، وده من حقه حقيقي، لان زي ما انتم شفتوا هوت في فحص يعني سيرفايكال سباين، اللنج فيها كريتيكال فايندينج. اوكي، فخلونا خلونا اطراف الفيلم السايد اوف ذا فيلم is very important also. ودي خدعة مشهورة جدا في كل الامتحانات especially يعني امتحان العربيك بورد is a big certificate. ماشي. you will be eligible to a consultant degree. ماشي. احنا بس بنقول كل التيبس دي to help all of you. Candidate number 3, this is a 35-year-old female patient presented with headache.
I
Can
will
you scroll?
present. Yes, I
Can
will
you
request a control.
request control? Okay. Go on.
Okay. I'm presented with axial cuts of non-contrast intensity. Starting with the presence of serpentuous hyperdense structure at the right frontoparietal region with surrounding vasogenic edema. Sorry, it's lagging with the scrolling. It's stuck on my screen.
Let me scroll for you.
Okay, I will.
Yes. Go on.
Okay. Okay, so again, hyperdense serpentuous structure at the left frontoparietal with surrounding edema. I don't see any shift of midline structures. I would like to scroll further down to assess any ventricular dilatation. There is no hydrocephalus. There is minimal crowding of the foramen magnum, indicating element of increased intracranial pressure. So this is an emergency. I would like to inform the referring physician and do further imaging to exclude an underlying mass lesion. Okay, so
What's your provisional diagnosis, doctor? Doctor,
sorry?
what's your
Yes.
provisional diagnosis?
So this could be an AVM, or it could be like a hypervascular mass.
What else?
It could be hemorrhagic infarction due to probably venous thrombosis. I see there is hyperdensified sagittal sinus.
So, what's your diagnosis?
So this is the severe sagittal sinus thrombosis with hemorrhagic venous infarction.
So, what's your next step?
So inform the physician, do an MRV or a CT venogram.
Okay. Go on.
This is sagittal MRI T2. I can again see the signal intensity, same location of the lesion with surrounding edema. I can also
Yes. Which sequence do you want?
So I will look at if there's an MRV of the sinuses, like the.
Okay. This is MRV and this is MRV. What do you think?
So I can see the superior sagittal sinus is maybe the internal this internal straight sinus is not visualized.
You usually see straight sinus. By the way, straight sinus is visualized. This is a straight sinus. Okay?
Okay.
Yeah. So which structure you didn't see?
Um,
Let me help you. Let's
okay.
in MRI, please, my colleague, start with the convention. Very conventional. T1, very important. Look here, my colleague. What is this?
There's hyperintense
Yes. Okay. Hyper intense in T1. What does it mean?
so it's like thrombosis particle.
Okay, thrombosed vein. Which name? What is the name of this vein? It is not in the sagittal sinus, either superior or inferior or straight. What
Cortical
is the name
vein.
here? Cortical vein. Very simple. Excellent. Okay. And then you found some hyperdense foci around it in T1. What does it mean for you?
Hemorrhagic content.
Okay, and this hemorrhagic content we confirmed here. What is the name of this sequence?
SWI. So there's
What
facile
again?
blooming. Uh,
What is the
SWI
name of
or
it?
gradient.
SWI, yes. So this is hemorrhagic content surrounded by edema. So what's your final diagnosis?
So cortical vein thrombosis with hemorrhagic infarction.
Hemorrhagic infarction. Okay. What is the name of this sign? Why this hemorrhage here in SWI is very black? What we call this?
This is the blooming.
Excellent. Why bleeding cause a blooming artifact in SWI?
The hemosiderin content
Yes.
is darkened as the blooming.
Yes, the hemosiderin cause signal loss because it is completely disturb the magnetic field. Why? Because it is completely paramagnetic. Okay? Sorry, ferromagnetic. So the ferromagnetic is very dark. The paramagnetic, something like gadolinium. Okay, so final diagnosis, this is a hemorrhagic infarction due to what? Due to this structure, which we see in T1. And this MRI indicates the importance of, where is T1? This T1. Importance of conventional and basic sequences. This is the curvilinear structure. And here also, you did very well, our doctor, when you pick up that inside this hemorrhage, there are a curvilinear structure here. This is a vein. This is a vein, and this is the key of this case. In any case, my colleague, of intraparenchymal or intracerebral hemorrhage, you should think about at least three things. Number one, metastatic hemorrhagic metastasis like breast melanoma. Okay. Number two, AVM. Okay. Number three, cerebral venous thrombosis, either cortical or dural sinus, whatever. But doctor, do you know why venous infarction is hemorrhagic? Do you know why?
Maybe the
Hello?
pressure
Yes.
in the vein increases, then it bleeds.
Excellent. Excellent. Because there are some element of venous hypertension. And so the blood pressure in the arteries is more higher in the veins. And finally, there are a competence, sorry, not competence. There are a conflict between the artery and the thrombosed vein. It ends finally by this hemorrhage, extraluminal extension or exiting of the blood due to conflict between the artery and the thrombosed vein. Okay. Do you know any other causes of hemorrhagic infarction. Hemorrhagic infarction. This is a question out of the exam, by the way, but I just enrich the discussion. Do you know any other causes of hemorrhagic infarction? I'm talking about arterial infarction.
Could it be like infarction following subarachnoid hemorrhage?
No.
Is that
I'm
no?
talking about infarction. Infarction, originally, the pathology is infarction, and it get some hemorrhage. Do you know? Like after perfusion. After perfusion, there are some infarction. Okay. Also, embolic infarction is very common to be associated with a hemorrhagic transformation. Reperfusion, correct. Candidate 5 said that. No. Hypertension is not associated with hemorrhagic infarction. Somebody, Dr. Nabi, said after thrombolytic therapy. Yes, this is means after reperfusion. Okay, my colleague. So, what is the different causes of hemorrhagic infarction? Number one, venous infarction. Why? Due to venous hypertension. Number two, after reperfusion. Reperfusion means either thrombolytic therapy or thrombectomy by interventional radiologist. Any of them is called reperfusion. Number three, I think in embolic infarction also, it may be associated with hemorrhagic transformation or some hemorrhage. Again and again, when you see any intracerebral hemorrhage like this, think first. Think, go up and down. Try to detect either curvilinear structure like this, and you will be run in the hemorrhagic venous infarction pathway, or you should detect any mass here. There are any mass here? Frankly, no. So this is not a hemorrhagic metastasis or hemorrhagic space occupying lesion. Okay? If you didn't detect mass and you didn't detect a curvilinear thrombosed vein or even thrombosed superior sagittal or inferior sagittal sinus, whatever. So think about AVM. Think about AVM. This is in case the patient didn't have at all any history of trauma. Because if this is a trauma, this is another entity. Okay, my colleague, at least now we revised the different causes of intracerebral hemorrhage. But here there are one very important sign. One very important sign. See here, this is surrounded with considerable edema, and this is not a common feature in AVM. Okay, my colleague, this is a common feature in venous infarction or a hemorrhagic space occupying lesion. Thank you, doctor, so much. Next candidate. Hello.
Assalamualaikum. Yes, can you hear me? Assalamualaikum.
Yes. Doctor, take care from this case. Okay? I warn you from the beginning. It is an easy case, but have an idea. This is a 20 years female patient presented with sudden onset of hemiplegia with no prior medical history. Could you scroll or shall I scroll for you?
Can you please scroll for me?
Yes.
Okay, I'm presented with the non-enhanced axial cut of the brain. The most striking abnormality is a hyperdense lesion noted in the right basal ganglia region, which is causing mass effect on the right lateral ventricle, as well as it has surrounding edema.
Yes.
Okay, there is some degree of hydrocephalus noted because of this abnormality. I am just scanning the rest of the brain to see for any other lesions. Okay, I'm looking at the sinuses to see if there is any hyperdense sign. I do not see any. The foramen magnum is not crowded. The basal cisterns are not effaced.
Okay,
I
once again, look
cannot.
here, my colleague. This
Yes.
is the normal foramen magnum. Very important. Thank you, doctor. Look, you
Okay.
can see this round structure. Either this is the upper cord, lower medulla, but at least you can see CSF around it here. Here. Okay?
Okay.
Not like before the previous cases. Go on, doctor. So what's your provisional diagnosis?
Yes, to summarize, this is a 25-year-old female patient with hyperdense lesion seen in the right basal ganglia. Most likely it is a form of hemorrhage. In my differential, I would think about it could be a hemorrhagic infarct, but it is less likely. It could be hemorrhagic transformation of a mass lesion, which is underlying it. I would like to proceed with other cuts to see the lesion properly. Or I also like to see it with the contrast enhanced if it's available. Okay. So this is a MRI axial cut of the brain. I would like to see T2. Okay. So T2 MRI brain confirms the lesion that we saw earlier. We can see that the lesion is hyperintense centrally with some areas of hypointensity as well. It is causing mass effect on the ventricle. Okay, also it is causing some mass effect on the adjacent midbrain. Could I also see T1?
T1.
So on T1, the mass lesion is heterogeneous.
Yes. What's your
Okay.
differential diagnosis? What's your differential diagnosis? Hello?
Hello, sorry.
Yes,
In
what's
this
your differential
lesion,
diagnosis?
yes, in this region of the brain, I would think of maybe like a high-grade glioma based on the age, 25
Why?
years,
Why?
because it's
Why this? What is the clue that you are يعني talking about glioma? Why you are talking about glioma? Do you have
it's
any
a
evidence?
highly vascular lesion, hyper
What?
dense on CT and high T2 on.
Yes, but I didn't give you any post contrast. How could you speak about
Yes,
vascularity?
you're right.
Where
Can
is,
I please
mm,
see post
do
contrast?
okay, this is the post contrast. So don't speak about the vascularity before
Okay,
this one. What happened?
okay. So
Do you
the lesion,
mm, yes.
yes, the lesion is having rim enhancement with centrally no enhancement or low enhancement. So I would like to also look at diffusion restriction.
Okay, but 1 second, please. Any hematoma may be surrounded by some inflammatory changes and may show this ring-like inflammatory hyper enhancement. Okay,
Okay,
where is? Do you have any solid component here? Yes or no?
not, no, I do
Hmm?
not see.
Are you sure? This is the
Um,
diffusion. This is the diffusion.
okay. Yes, the diffusion shows some areas, maybe the internal septa that show, yeah, restriction.
Okay. Uh, could you request the mouse to show me either you have see I will help you. I will help you.
Okay,
See here, this is the gradient. So this is the hematoma. or the hemorrhage.
Yes.
So all you see, I will help you more. Look here. What did you see here in post contrast?
So
Ring-like
some,
enhancement
yes,
surrounding. See, look, surround the hematoma. This is
yes,
enhancement surrounding the top. Even this is hyperdensity, almost surrounding the hematoma. Is it clear for you?
yes.
My question. Do you have? See, look. Exactly, this is indicating inflammatory changes surrounding the hematoma. My clear question, do you have any clue or any solid component?
I'm not sure, doctor. Maybe like few
I will help
areas.
you. When we are confusing, I just told in the last case, we should bring the conventional MRI, T1
T1.
and T2.
Yes.
Okay, look here.
Yes.
Where, doctor, request control, please.
Okay, let me try. Um,
Could you Could you know how to
I,
request control?
no, doctor.
Okay, no problem, no problem.
Okay,
This
I
is
got it, I
T1.
got it. I got it.
Okay,
Yes.
thank you. See, my colleagues, this case will show us the importance of basics for MRI. Doctor, could you show?
Yes.
No. Let both of them. Don't move, please. I give you the slice which contains the answers.
Oh,
Don't move. Look,
sorry.
in T1, normal T1, normally in T1. The white matter is high or low?
No.
In another in
Sorry, sir.
another word, in another words, look at the left-sided basal ganglia. This is
Yes,
side, okay?
compared to, yes.
Is this thalamus looks like this one?
No.
Okay. So there are some pathology here. There are
Yeah,
some
so most
pathology.
likely at the thalamus, the right
Yes.
thalamus.
So if this is the hemorrhage, this one, the hemorrhage, and this is
Yes.
the which not looks like the contralateral thalamus. What doesn't it indicate for you? There are
So
something
that
here.
means, yeah, it has a solid component.
Second point, this signal abnormality exert mass effect. Are you agree with me or not? Look,
Yes.
look here. Does it see completely effaced the third ventricle? Okay, especially here. See, convex border. So this is a mass. This is a mass. Are you agree with me?
Yes.
You agree? Look here. Look. Where is the hemorrhage? This is the hemorrhage. The black one, and this is
Yes.
edema. Look beside him. What is this? Rounded space occupying lesion. So they ask for MRS. I think it is that one or where? What confusing here that this is not well enhanced. So the consultant asked for this one. What is the name of this exam or this
So
sequence?
this is MR spectroscopy.
What do you think this is normal or abnormal?
It's abnormal because the choline to creatinine ratio is high.
Yes. What does it indicate? High
So it
choline,
indicates,
low NAA, and increased choline creat ratio. What does it mean for you?
it means malignant lesion.
See, not malignant. This is a mass lesion.
Mass lesion, yes.
Yes, in brain, we didn't say malignant, either aggressive or non-aggressive, or low grade or high grade. Okay, so at
Yes.
least we are talking about a mass. Is it clear for you?
Yes.
By the way, this is it is a very difficult case, so
It's
yeah,
a,
don't worry. Yeah, look
thank you.
here. Yeah, look here. In comparison with the contralateral side, this is the contralateral side. Hey, look here. 1 second. Very important, very important to compare. Usually compare whenever possible. What happened? This is the diseased site. We will do in correlation with the other side. What happened here? There are elevated choline. In comparison to the normal side, this is the normal one. Why? Here in contralateral side, this is the normal one, like the three pyramid. Do you know the Egyptian three pyramid?
Yes.
Do you know what happened? This is the normal one. The larger one, this one, the NAA. Then the creat, then the lowest one should be choline.
Cool.
Okay, completely reversed here due to some pathology. Why? Because the choline is a cell membrane, cell membrane, I think choline is phospholipid. When the number of the cells increase in malignancy, and the turnover is increased due to high turnover and the destruction of aggressive lesion, the choline is increased, but the normal neurotransmitter, which NAA, is decreased. And the creatinine, which an indicator of the viability. Creatinine, what does it indicate? It indicates the normal uh, biochemistry or metabolite of the cell. Okay, the normal is decreased in any aggressive lesion, and the abnormal is increased. Is it clear? Is it clear, doctor? Hello?
Yes, doctor.
Yes. So what is this high-grade glioma with hemorrhage? Hemorrhagic space occupying lesion. By the way, it is very difficult case. I bring my voice is clear, my colleagues, or not?
Yes, doctor, we can hear you.
Is my voice clear or not?
Yes, it's clear.
Okay, I will revise it again. Okay, I will revise it using some Arabic words, please, because it is very difficult and maybe a new case for some people. What happened? The examiner gave a very misleading case because in the beginning أنا قلت لها في البداية the patient has sudden left-sided hemiplegia. وأنا قصدت أقول كده. I mean that to mislead her. That the patient has a sudden left-sided hemiplegia. And this is very common, by the way. And the patient is so young. What happened? There are very clear hemorrhage in the basal ganglia. What come in mind? This is a hemorrhagic hypertensive hemorrhage. Very clear. No any doubt. Why? Because hemorrhagic intracranial hemorrhage due to hypertension is commonly seen in the basal ganglia due to end arteries. Very common sight. But I told you in the last case, look up and down, search for two things. Curvilinear structure, no curvilinear structure. Then search for any mass lesion. Okay, here really very difficult. يعني I excuse our colleague because very difficult, but you should compare the diseased site with the contralateral site. See here the thalamus, almost oval shape, but here there are something rounded and with irregular border. Okay, and after contrast, look well, please, look well. There are something here. At least make a doubt. Tell the examiner, I have a doubt about this one. Please, I want MRI, post-contrast MRI. Okay? He will be very happy. الاكزامنر هيبقى سعيد جدا حتى لو انت شاكك في حاجه ما هياش اكيده وقلت له بس نعمل له MRI مش هنخسر حاجه. احنا كده we are saving the patient life. ايه اللي حصل هنا بقى يا جماعه؟ لازم في الMRI عنده مشكله كبيره. الMRI في الهيموريدج مش الطف حاجه. عشان تشوف الهيموريدج محتاج مثلا SWI، ماشي، وعشان تشوف السوفت تيشو كويس محتاج سيكونس تاني. احسن حاجه الMRI دايما. للزملاء اللي بيشتغلوا MRI عارفين الكلام ده، احيان كتير جدا بتضطر تشتغل كده فاتح 4 ويندو مع بعض. صدقوني like this in MRI almost you should open more than one window like this. This is T1. This is post contrast. This is SWI. Where is SWI? No, this is the gradient. Okay. And finally, this is T2. What happened? This is the hemorrhage. Okay. So this is the hemorrhage. What is this? This is beyond the hemorrhage. What is this? This is beyond the hemorrhage. Unfortunately, the lesion, despite it is a high-grade glioma, it show very faint or very weak contrast uptake. Okay, but the other sequences, especially the conventional, this is a case of conventional T1 and T2. Look here, the solution or the clue is here. If you compare this thalamus with here, you will find a very big difference. There are something here. If you compare here with here, you will find something different. So it looks like a mass lesion here causing this hemorrhage. Even if you are wrong, even in your normal practice, if you are wrong, this is as long as you are trying to save the patient, you are not wrong. يعني لو انت شاكك للأسوأ، أسوأ سيناريو، ده شيء كويس على فكرة. يعني هات حد كونسلتنت كبير يساعدك يشوفها. على فكره في الاف ار سي ار يا جماعه مسموح جدا ان احيانا بنقول للاكزامينر I need a help from a more senior consultant، وده acceptable جدا. ماشي، احسن من ميست كيس. اوكي، ايه اللي حصل هنا؟ احنا جبنا الماس دي بالتي 1 والتي 2 and this case show how much the importance of T1 and T2 sequences. Very important. So again and again, when you are presented with MRI, please have a look at the T1 and T2. Please have a look around the lesion and above and below it. Why? Because finally, it is a very big disaster. What is this? High-grade glioma. High-grade glioma, and almost the patient will not يعني still alive. Okay, very big disaster and a very dangerous diagnosis. Thank you, doctor, so much. Again, I will revise what happened. This case was intracranial hemorrhage due to hemorrhagic space occupying lesion. The case before was a hemorrhage due to hemorrhagic venous infarction. So don't satisfy with search when you are presented with hemorrhage. You must try to pick up any clue, any cause, any pathology. This is our main task as a radiologists. Okay. Thank you so much. This case show us many of the basics of the MRI. Next candidate. This is the normal MRS. Okay. This is the abnormal MRS. What happened? Choline is high and the normal is low. What is this? Lipid and lactate is high in case of necrosis or in case of abscess. Okay, my colleagues. Next candidate. Hello?
Yes, here with you, doctor.
Yes. This is 35-year-old female patient presented to the emergency department with headache, dizziness, and left-sided weakness. Can you scroll, doctor, or shall I scroll for you?
No, scroll for me, please, because I'm on the phone.
Okay, go on.
How old is the patient, please? Again?
5.
5?
35 years old. See,
35. Okay,
30.
thank you.
Adult female patient presented with to the emergency department with headache and dizziness.
Okay, I'm presented with a head CT without contrast. The most striking finding for me is okay. I have multiple findings. I have the posterior horns of lateral ventricles are some sort of dilated colpocephaly, I think it's called.
Yes.
Yes, and can you scroll further down for me? Okay, there is another hypodense area in the left, in the right CP angle.
Yes.
Okay. Um, um,
What else?
is there any other cuts like coronal
No, this is the only
or
available
sagittal?
one.
The only available one. Okay. There is no significant edema, I think, or no media, uh, no shift, no midline shift
Yes.
or mass effect. Can I see the foramen magnum, please? No crowding of the foramen magnum.
So what's
Um,
your diagnosis?
um,
What's your
in,
diagnosis?
I'm thinking of either cerebral, cerebral artery, but it doesn't look like infarction. I don't know.
See, let's recap what you said before. You talk about bilateral colpocephaly.
Yeah, I'm thinking about um,
Yes. Mute yourself, please, my colleagues.
idiopathic.
Yes. Okay. Hello?
Hello, yeah, with you, doctor.
Yeah, but what else? What happened for the lateral ventricles?
Colpocephaly, it's a sign of idiopathic
Yes.
idiopathic increased intracranial hypertension.
No. Look here.
Idiop
Look here for both frontal horns. What happened for them? If I told you, I give you a very misleading history. Despite this is, by the way, this is the history. I didn't mislead you, but the history completely is misleading. What do you think about colpocephaly?
cor
And
corpus callosum hygiene says
excellent. And what is this?
this is cavum.
No.
No, this is
Okay. What is your next step for this patient?
lipoma,
Okay. See, we
pericallosal
request
lipoma.
this. Yeah, this MRI for this patient. What is your diagnosis here?
This is corpus callosum hygienesis.
Okay, and what is this?
It can be either arachnoid cyst
Okay,
or but I should check other sequences because
okay.
it can.
Do,
Okay.
do you detect anything else? Look at the orbit, please.
Oh, there is also large.
Right, right or left?
No, right.
Right. What did you find?
Is this glioma or meningioma? Can you scroll for me?
Persist or maybe assist. So
Maybe
so
assess. Yeah.
finally, it was a case of multiple congenital anomaly. Correct?
Hmm. Yeah.
Is it clear? Okay.
Hmm.
In case like this, we must ask for sagittal to rule out any Chiari. Look here at the corpus callosum. No corpus callosum at all. Thank you, doctor. It is very tricky case. Okay. Um, Also, thank you, Dr. Rania. Thank you so much. You pick up very, very difficult point. I will comment. What happened, my colleague? T, either FR or either MD or PhD or Arabic board, all of them are يعني the highest degree regionally. So the examiner may present anything like very common pathology like this, corpus callosal agenesis, but he play with you. Why? The age is adult and the presentation is acute, but finally this is congenital anomaly. Trust in what your eyes say. This is the advice of this case. You see corpus callosal agenesis, tell the examiner. And after that, till I'm searching for hemorrhage, for any vascular occlusion, I can't find. At least you pick up most of the finding. What happened here? There are bilateral colpocephaly and bilateral parallel frontal horn, pill horn sign. Okay, and there are many cysts. CB cyst here, and the right parasagittal cyst here, and the orbit. Look here. And one excellent doctor pick up something in the MRI. I think it's not clear here in the CT. Look here, my colleague. What is this? What is this? Subependymal nodules. It is almost heterotopia. So, so polycongenital anomaly. Okay, whatever the name of this syndrome, at least you enumerate correctly the different signs and the different name of the anomaly. This is, by the way, a cardia syndrome. This is a cardia syndrome. But the most important for me is that you should enumerate the different type and describe them well of anomalies. And don't be tricked by the misleading history. Thank you, Doctor, so much. Next candidate.
السلام
Hello.
عليكم.
Alaikum assalam. Doctor, this is a 45-year-old male patient presented with back pain and bilateral lower limb weakness. Go on.
Okay, so I'm presented with MRI of the spine for a 45 years old male with back pain and lower limb weakness. I would like to have a general look before starting my comments. So this is T2 sequence of the dorsolateral spine. There are abnormal signal void, multiple curvilinear structures seen extending along the mid-dorsal cord, I mean the lower cord, and the Yes, mainly
Yes.
along the lower cord, associated with abnormal high signal on the distal part of the cord. So these could be representing vascular structures, could be the ends, and the lower cord high signal could be due to serums. I would like to check the rest of the sequences. I would like to look for the T1 for further characterization. Yes, on the T1, I'm looking
Here.
for any high signal to check for any evidence of bleed, which is there. I would like to look for
Here.
any evidence of compression, any evidence of abnormality on the thoracic vessels, namely the aorta, that could be associated vascular abnormality,
What's your
which I
diagnosis,
cannot
doctor?
see. So this is ABM of the cord. I would like to check the post contrast or the
Are you sure? Are you sure AVM of the cord?
okay, it's extradural. So
Yeah,
it
yeah.
is
This is AVM of AVM
okay.
or something else.
Okay, the other differentials for vascular lesions هما hemangioblastomas which I cannot see.
بس لسه يجيب
So I
بعد
will go
خلاص
with AVMs,
يجيب
dural
بعد خلاص
AVM.
One second. Please, my colleagues, mute yourselves. Doctor, you are in the correct pathway. Don't deviate. انت صح
Okay, so
كملي.
dural
But the name
AVM.
is not correct. Dural AV
M.
or
Okay.
AVF
Okay,
or
AVF.
AVF. Yes, very big
Okay.
difference. Why? Because there are no any difference. يا جماعة في فرق كبير ما بين ال AVF arteriovenous fistula and EVM. EVM are يعني vascular malformation. another entity. Why? Because EVM should have a nidus here. This is just vascular channels. Due to what happened,
Okay.
there are abnormal connection between the artery, the dural artery and vein. What is the most common cause, doctor? See?
Okay.
Dural, spinal, dural, AV fistula, arteriovenous fistula. So sometimes we forget, sometimes some examiner ask you, what do you meant by EVF, EVM? Why he wanted to check if you understand the abbreviation or not. There are a very big
Okay.
difference between them. What is the most common cause of EVM? Sorry, EVF.
Okay. Could be, yes, post-intervention, like previous surgeries, trauma, or could
Yes.
be iatrogenic or
Okay.
infection.
Thank you, doctor. Thank you. What happened here, my colleagues? There are multiple vascular channel here. Very characteristic. مميزة جدا يا جماعة عشان بس ما نغلطش فيها وهي سهلة. اوكي. لما نشوف الكورد السيجنال بتاعته ابنورمال كده وحواليه فاسكولار تشانل كده، خلاص دي اي في اف. يعني لازم اقول لكم على نصيحة كده. سوري تو سبيكينج ان Arabic I will translate in English. اقول لكم على نصيحة، يعني قالها لي حد استشاري جميل جدا من اول ما بتتأشع، قال لي اما تمسك الحالة، بص انت عايز يعني في الاول دي رايحه فين الحاله دي؟ يعني ايه رايحه فين؟ يعني الحاله دي انت عايز تكتبها ايه؟ عايز تشخصها ايه من البدايه؟ وبعدين ابتدي قول التفاصيل. مش تقعد تقول تفاصيل التفاصيل وبعدين تبقى ماشي غلط. يعني هنا زي ما قلت لكم هما two buzzwords. From the beginning you should know in your mind you should decide what is the diagnosis. What happened here? Swollen cord with abnormal signal plus multiple vascular channels. This is means in your brain this is AVF. Then describe all the details, whatever you will describe. Okay? So from the beginning, both for yourself the proper correct track. Is it clear for all of you? وبعد كده طبعا يعني هنبص على بقية الفحص وكل حاجة. ماشي؟ اوكي. Next candidate.
Yes, sir.
Yes,
Can you scroll for
Dr.
me?
Yes. This is a 50-year-old female patient presented with headache and vertigo.
Very converted. Okay. This is axial cuts, MRI brain, T1,
Yes,
which showed abnormal high signal at the level of basal ganglia bilaterally.
yes,
Rest of brain appear normal, no mass effect, no hydrocephalus. I would like to check in other sequence, T2.
okay,
T2, I can see abnormal high signal.
yes,
Uh, at bilateral deep white matter
okay,
and at very ventricular area. I would like to check basal ganglia again to look for abnormal signal. Okay. Basal ganglia showed previously seen high signal as low signal on T2.
yes.
Mm, okay. I would like to check other sequences.
Which sequence? The last sequence that you will request now. Only one.
SWI.
This is the BI.
I can see area of blooming artifact at periventricular area, as well as bilateral basal ganglia, and bilateral cerebellum. I think this is dentate nucleus.
So,
The diagnosis will be abnormal signal, likely calcification of
so, but
the.
doctor, are you sure this is calcification? This is bright in T1.
Uh-huh.
Are you
So
sure?
this is depositional. No, this is depositional. This is
Okay.
depositional, likely depositional.
What do you mean by depositional?
Likely mineral deposition. Because it's
Okay.
high paramagnetic, high in T1 and low in T2.
Okay. What's your provisional diagnosis?
The exact location and high mineral deposition suggest a depositional disease such as
Yes.
hepatic encephalopathy.
Okay.
Number
By
one.
the way, maybe also calcium. I
Mhm.
just asked you, I didn't mean that you are wrong. You may be correct.
Mhm.
I want to if you will insist in your answer or not. So
Because it's
what
high
is
in T, it was high in T1 and high in T1. So this is a paramagnetic effect. Could be depositional due to mineralization.
yes, yes, yes. What
Mhm.
type of look at the location, basal
Mhm.
ganglia, then dentate
Dentate
nucleus.
nucleus.
This is a very classic
Wilson.
deposition. No.
Wilson
What else?
disease.
No. What else? And in the corona radiata.
Hemochromatosis.
No.
Mhm.
There are very characteristic disease. This deposition could be calcium or not? Yes or no?
Yes, could be.
Okay. In any stage, calcium can be high T1. Do you know?
No.
Immature calcium can be high in T1. So,
Okay.
if this is calcium, what is the name of this disease?
Fahar disease.
What?
Fahar disease.
Bar disease or fire disease, correct. What happened here? The examiner may play with you or يعني بيشككك عادي ده مقبول. Okay.
Mhm.
What happened if you are trust
In
from
doubt.
your answer? Don't doubt. Why?
Mhm.
Because this is uncommon information for most of us that calcium can be high T1, can be of high T1 if it is immature calcium. Immature
Okay.
calcium can be high T1, like this one. Okay, my colleague. Second point,
Okay.
it is a very classic look at, especially in SWI, what happened basal ganglia, corona radiata here, and
Mhm.
then down dentate nucleus. Okay, so this is very classic. The distribution very, very classic to the phases. Doctor, a last question. Last question. What is the surrounding bright white matter? What does it indicate? What does it indicate? Okay.
Gliosis. Could
Yes,
it be a
why?
gliosis? Yes.
The patient is 50. يعني this is white matter brightness is too much for his age. But
Yes.
this is gliosis due to the insult that happened by this calcium deposition. Okay, so this is a classic far disease, but in MRI. One of our colleague asked me, send me some notes before the session, and by the way, he told me it's very common in Arabic boards that they give us very common diseases, but in atypical location, like this
Mhm.
one. All of us can answer the fact this, especially if in CT, but in MRI we are not familiar. It is not familiar to us. And this is the
Yes.
importance of our lecture. Thank you, doctor, so much. Last
Thank you.
candidate and last case. Thank you, doctor. You did very well, by the way.
Thank you.
Last candidate.
If some emergency happened to him, he can't join.
Okay, anyone wanted to share? Anyone wanted to share? Okay, I will answer this one by myself. Okay, my colleagues, what happened here? This is a 40-year-old female patient presented with low Glasgow coma skill. Okay, so it means something critical from the beginning. From the history, you can guess something. What happened here? This axial T2 MRI. What happened? Bilateral symmetrical signal, bright signal abnormality in both salami. Okay, I will immediately have a look at first T1. Why? In any emergency, roll out hemorrhage from the beginning. This is not related to hemorrhage at all. Second, I will see. So I'm worried about the other pathway. What is the other pathway? Infarction. What is this? This is the DWI. Okay, DWI show high signal. So I must be sure, yes, load ADC. So this is a true restricted diffusion. So we are dealing with a restricted diffusion. It means one of two things. Number one, infarction. Number two, and least likely, mass. Why is this less likely to be mass? Because it is very symmetrical and bilateral. Okay, so I will speak 90% of my discussion about the infarction. This is either venous infarction and arterial. In my opinion, I will have another look in T2 or in flare to check is it surrounded by too much edema or not. Where is the flare? This is the flare. No, nearly no surrounding edema. Okay, it is just the infarction itself. So it looks like to be arterial more than venous. Number two, see here, apart from this foci of it may be mineral calcification or something like this, there are no hemorrhage. So it is almost something related to arterial occlusion. It is likely to be arterial infarction more than venous infarction. How can we be sure? Number one, we will ask for MRA or MRV because two differential diagnoses here. Either occlusion of artery of Percheron or occlusion of the inferior sagittal sinus or straight sinus or internal whatever. Okay, so what will we do? We will ask for MRV and MRA. If the examiner gives you this one, why? Because if you have a look here, okay, you will see the MRA nearly completely normal. Why? Because this artery of Percheron is very difficult to be seen here. Very difficult. Okay, so don't consider this normal MRA is an exclusion to arterial infarction due to artery of Percheron occlusion. Okay, what should we do next? Also, again, have a look about the signal void of the sagittal sinuses, all the dural sinus. This is superior, which is very far. But go down, 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 down. What happened here? This is the right internal cerebral vein, this one, and this is the left. Again, this is the right one, okay? This is the left. As you see, it is completely signal void. So it is normal. Okay, my colleague? Go up, up. This is the vein of Galen. And this is what happened? The confluence. And this is a street. All the venous sinus has signal void. So we excluded the venous infarction. So this is an artery of Percheron occlusion. What is an artery of Percheron? Normally, H salami is supplied, has arterial supply from the PCA, H1, okay? Direct perforator from this one, BCA. Here. Sorry, one second. But in some cases, this both sides are fused in single trunk. This is the BCA. This is the BCA. Each one should supply directly the thalamus. Sometimes both of them are giving one trunk called artery of Percheron. When it occluded, it gives this sign. Okay, my colleague, I will give you last bit here about the cerebral veins. What is the cerebral veins? Originally, we have all of us know the dural sinuses. Okay, the dural sinus, this one, the superior sagittal. Okay, and the inferior, and this one, the transverse, and the transverse here. Okay, but there are something else here. Look here, all of these are cortical veins. Okay, these cortical veins directly, many of them directly drain into the superior sagittal sinus. Okay, when some of them or one of them occluded, it causes cerebral infarction. Okay, all of this are especially the cortical veins are superficial vein, but we have the deep veins. What is the deep veins here? Here, perpendicular to both ventricles, there are some medullary veins. I think there are one very clear is the look here. This is the medullary veins. This one, the cortical veins here drain in these medullary veins, go down, down, down into the subependymal veins, and in both sides, by the way. And all of this collected here at the venous angle of internal, three veins are collected, united with each other, the ependymal and the choroidal and another third one. They form both internal cerebral vein, and both internal cerebral vein form the vein of Galen. Okay, this is not so much important, but I describe for the idea to be integrated in your brain. Okay, my colleagues, any doubt, any question? I will announce for, I think, another session for Arabic board, and for FRCR, they know their lecture. Anyone have any question? Thank you so much for our coordinator, Dr. Osama, Dr. Asara, Dr. Samia, everyone who helped me to achieve this first lecture. Special thanks to Dr. Abdullah from National Cancer Institute, and all of you. Thank you. Study well, stay motivated. You can do it. My YouTube channel is full of more than 100 video. Okay, I will share the link, or most of you know the link. Study well, study hard. Thank you. Good.